Hi, I'm Leslie Marie Buer. I am the research director at Positively Living Choice Health Network. And we have offices in a few places in East Tennessee and outreach locations as well. And so I want to share the lens I am coming from because I think that affects how we all, talk about our topics of interest. So I'm a medical anthropologist, and I think what that brings to me is, I'm really interested in structural issues, definitely not in blaming the individual or looking at individual interventions necessarily. And I'm also really interested in including the cultural beliefs and social movements behind many of the policies and politics we see, especially in Appalachia in the South. I'm also a harm reductionist. When I say that, I mean a harm reductionist with a capital H and capital R. And that's actually from a nice article in Filter that you see the title of here. And I encourage you to check out this article if you're interested in sort of what I mean when I say that. But I mean, for me, I think harm reduction is not just about reducing health risk. It's about supporting a social justice movement led by people who use drugs. That it definitely includes slinging needles and naloxone, but it also includes advocating for decriminalization, abolition, affordable and available housing, reproductive justice. It's acknowledging all of the aspects of our society and environment that negatively affect people who use drugs. And also, when I say capitalized harm reduction, I'm pushing against a type of sort of bait and switch harm reduction that we are increasingly seeing in the South and in Appalachia, where people are sort of lured into a program because they're offered maybe a few bags of syringes, and then they're coercively guided to an abstinence-only treatment program, right after they're given some harm reduction supplies. Or what we also see a lot is people being sort of sold what they think is a buprenorphine program, but once they're sort of in, they realize that they will be tapered in very, very quickly, sometimes in 4 to 6 months. And then they're guided to use Vivitrol, which most folks we talk to, it doesn't work too well for them. And then there's also some peer-reviewed evidence that shows some overdose risk concerns with Vivitrol. And so when we talk about harm reduction, it's really about autonomy, not coercion, and about providing clear services that people say they want where they're at. So that's just sort of the lens I'm approaching this with. And so a lot of also what I wanted to talk about, and as a cultural anthropologist, is some of the cultural beliefs behind bad policies. And oftentimes when we think about bad policies, we want to sort of blame this omnipotent power at the top, or certain legislators or so forth. But these ideas are not born in capitals. They're born in our everyday culture. They're born in the places where people grow up and from the voters who vote people in. So when we talk about sort of bad policies, I think we all have to look at ourselves too, and what are we doing to support these bad policies? And so I just wanted to show some examples of discrimination in the place where I'm mostly at is in Knoxville, Tennessee. The one on the left, unfortunately, we see a lot on cars around town. And advocating this type of violence against anyone is pretty repulsive in my opinion. But just imagine if you're someone who connects people with drugs or cells, seeing this, it's telling you that your community wants you dead, it's really powerful. And the one on the right, I think, really shows, especially in East Tennessee, I've noticed there's a special hatred of pregnant people who use drugs. Honestly, there's a long history of hating a lot of pregnant people in Appalachia, whether they use drugs or are poor or are just in Appalachia. And so, but this is shown here. And what's so sort of heartbreaking about this is if you look at the statistics of babies in Knoxville born with NOWS, neonatal opioid withdrawal symptoms, most of those symptoms can be actually attributed to doctor prescribed buprenorphine. So this sign is basically telling people that they shouldn't trust their doctors and that they shouldn't be relying on evidence-based medicine. And so, all of these types of discrimination are influencing the policies we see. And there's this idea that drug use is a moral failing, and that idea is not going away. And thus people who use drugs deserve to be punished. But this discrimination against people who use drugs is also intersecting with other types of discrimination. And the sentence I just said, drug use is a moral failing, you can insert all sorts of things there. So people are also saying poverty is a moral failing, and thus people who are poor deserve to be punished. Or sexuality outside of heteronormative marriage is very heavily stigmatized here. Blackness is heavily punished across the US. So there's all these ways in which discrimination against folks based on maybe one action or their social status is turning into these policies. And of course, these aren't things, as much as I can talk about the failings of Nixon's drug policy and the failings of the war on drugs. We can't just trace these things back to the mid-20th century. They have deeper historical roots than that. Sort of a lot of this hatred against drug use is going back at least 100 years, and then hatred against people who are poor and all these other social places that people are holding. Long roots of discrimination, both within the community and within social systems. So example of social workers, of medical workers going into Appalachian communities from the early 1800s and policing people's autonomy and policing people's families, and sort of doling out a lot of discrimination and a lot of punitive approaches. So all that is to say, in order to work on these cultural beliefs, it's going to take a lot of community education and organizing to change these things. And sometimes harm reductionists are expected to do that, but it's hard to do that when you're also trying to deal with delivering a lot of services. And so any support I think we can have in doing some of that community education would be much wanted. But of course, these cultural beliefs do affect politics. And I know a lot of folks are very familiar with the policies that across the US that are threatening, ending hepatitis C and even preventing transmission of Hep C, even just to keep us at a stasis. With where that's at. And so I'm not going to go into things that I see as affecting sort of people across the board in the US, but I do want to point out a few things that may not be unique to Southern and Appalachian politics, but I think are particularly pernicious here. And so one is certainly the efforts to prevent harm reduction from even happening. So several states, it's still illegal to provide syringes. And even in states where it is legal, such as Tennessee, there are so many hoops to jump through to open a harm reduction program. It becomes nearly impossible to open up new ones because of sort of new policies that have been put into place. So if you have a program that has been maybe grandfathered into those policies, it's kind of okay. But if you're trying to open up a new place, it's nearly impossible. And a lot of that pushback, unsurprisingly, is coming from law enforcement in Tennessee at this time. In order to open up a new syringe service program, You have to have a letter of support from law enforcement, and politically in this state, a lot of agencies, law enforcement agencies, see that as political suicide. And so getting that letter of support is going to be nearly impossible. And they might tell you behind closed doors that they're okay with it, but actually giving a public letter to support a harm reduction organization, that's going to be a rare thing to happen. The other, I would say, biggest opponent to harm reduction are often realtors and planning commissions. And so a lot of that has to do with efforts to gentrify places, but also just efforts to prevent harm reduction from coming into a city. And so we've seen planning commissions oppose syringe service programs, as well as buprenorphine programs across different cities in East Tennessee, as well as Western North Carolina, and maybe beyond that, but those are the examples I'm familiar with. And then you have efforts to fully dismantle harm reduction, which was unfortunately successful in West Virginia the previous year. And there's some data coming out of West Virginia. Of course, this harm reduction dismantling happened in the middle of an HIV outbreak, and that, of course, with no new syringes and no harm reduction program, that has continued to worsen, to my understanding of knowing some folks on the ground there. And so, and similar efforts were brought about in North Carolina to dismantle harm reduction in that state, but luckily those were thwarted by a very organized group of pretty amazing activists. So, some other things that are sort of affecting folks who use drugs here and preventing them from accessing services might be some evidence-based treatment programs, especially for substance use disorder, are often overregulated, and that is particularly true for buprenorphine and methadone. And you have law enforcement, staking out buprenorphine clinics, which scares people off. And then we also have a hard time for people once they do get a buprenorphine prescription from actually filling that prescription at a pharmacy. And there's a great recent article, it just came out a few days ago in NPR, that focuses on a few providers in Western North Carolina, so still in Southern Appalachia. And they really talk about how the DEA targeting of pharmacies who are providing buprenorphine services is really harming folks. And we know that if people can get into a buprenorphine or methadone services, oftentimes it provides a level of stability in their lives, which we know if people, that provides opportunities for testing for things like HIV and hepatitis C, as well as provides sort of an environment that makes it less obstacles, let's say, to getting HIV and hepatitis C treatment. On the other end of the spectrum, while all these evidence-based programs are being overregulated, we have an underregulation of abstinence-only treatment programs. Another good sort of a pop culture reference for this is there is a Reveal podcast about American Rehab, but they also offer some really good peer-reviewed resources if you go to their website and so forth. And it talks about how different abstinence-only treatment programs across the South, and we have experiences locally as well, turn into nothing more than work camps. And there's really not much treatment going on there. And these can be somewhat dangerous places. And some of the issues that come out of this are not only are you not getting good treatment, but we know when you go to this type of treatment, overdose risk increases dramatically when leaving. And it also builds distrust with the entire medical system. So if you go into something that you associate with the health system and it treats you poorly and doesn't really do anything positively for your life, you're less likely to trust the medical system and go in to get things like Hep C testing and treatment. And a similar process is happening with hospital IV drug use protocols, which have spread pretty rapidly in East Tennessee, but some of the first ones I was aware of were actually in Western North Carolina. And of course, these vary from hospital to hospital, but what it primarily entails is a lot of searching, surveillance, and criminalization of people who inject drugs once they are admitted to a hospital, to the point that it greatly, it completely isolates people, which with COVID-19 in hospitals right now, I understand that there's a lot of isolation happening regardless of drug use status, but this was implemented before COVID. And it has led so many folks to refuse to go to the hospital. One key thing is also they take away your phone completely. And if people know that they're going in for a long time, so not only can they not have visitors, but they also can't have a phone to communicate with anyone. So we have people who have said that they are refusing to go to the hospital because of the discrimination they face there. And they said that they would rather die, and then they have died. And then we have other folks who are, have said that I'm not going to the hospital until I go unconscious. And then they have a family member take them to the hospital. And at that time, it might be too late for anything, or it might be an infection has spread to the point where they have to lose a limb or lose certain abilities. And so, once again, this is just creating a complete distrust of the medical system. And it's really hard for people to want to go get treatment when this is what they think they're going to face or what they have faced in the past. And of course, availability of care is an issue as well. And so there's, of course, an urban-rural divide in availability of care. And if you see on the left-hand screen with pictures, shades of blue and green, the dark blue represents the urban areas, and the sort of white represents very unpopulated rural areas. And I've worked and lived in both of those shades. I'm currently in the dark blue, but previously I've lived and worked in the white. And I can tell you, I think there's a stereotype that all rural areas don't have health services, but I think that really varies by county to county and regionally and from state to state, depending on what type of health system you have happening in that area or state. But I would say overall that rural areas, there may not be an option for treatment available, for Hep C treatment available at all in the county. And especially it might not be available for locally for uninsured folks or for people who use drugs. There might be simply refusal to treat people who use drugs for hepatitis C if they are currently using. And of course, that can become the case in urban areas as well. And our experience working in both urban and rural East Tennessee right now is that there is an incredibly low availability for people who are uninsured for Hep C treatment. And it's an even lower availability for people who use drugs who are currently using. And of course, that results in really long wait lists. And oftentimes, having to go wait for hours on these wait lists and so forth. So it's just not easy to get. It is a triumph for us to get someone connected to care. And, we've RNA tested hundreds of people, and I think we've gotten a few in to actually get care. And that's shows a lot for what they did to do that. Just so many phone calls and so much waiting. So it's just not really available for most of the people who we're serving through a harm reduction program. But so I feel like I've talked a lot about the bad stuff. And sometimes we get bogged down in that in harm reduction because it's just hard sometimes, but there are so many successes, and definitely from related fields sort of adjacent to Hep C prevention and treatment. And so I've lived and worked in both a Medicaid expansion state, or at least it was while I was living there, Kentucky, and now I live in a state without Medicaid expansion. And I think in terms of buprenorphine, I have just seen a huge difference in access between a state that did have expansion and a state that didn't. And just some of the numbers from Kentucky, these are numbers from the year before Medicaid expansion was implemented and then the year after it was implemented. So the uninsured rate for opioid-related hospitalizations dropped 90%, and then there was a 700% increase in Medicaid beneficiaries using substance use disorder treatment, and that was primarily buprenorphine with some counseling services, which is required in Kentucky. And so you see that, I do not want to coerce anyone into treatment, but you can see if you expand financial access, people will use it, which is, fantastic. And I think if you look at the naloxone distribution through harm reduction programs, that is a success of what folks will do. And so if I look at our numbers from East Tennessee in 2020, we distributed about 100,000 doses of naloxone, and 3,500 of those doses were used to reverse over 1,500 overdoses. And that's one program in one city. And in 2020, we were closed for a few weeks for COVID. And then we were all scared, of course, like everyone else was, and we weren't doing a great job collecting data last year. But still, it shows that our participants, reversed 1,500 overdoses, which is many more overdoses than first responders in our city were reversing. And so I just want to, note when it comes to thinking about Hep C prevention and treatment, the amount of mutual aid and unpaid labor within communities of people who use drugs is simply astounding. It's, there's stereotypes of people who use drugs as only having toxic relationships, of being unable to care for one another. But naloxone in and of itself shows that is simply untrue. And so I want to acknowledge that unpaid work, but also moving forward, I encourage people to think about ways, whether you're thinking about Hep C or HIV or preventing overdose deaths, how do we support that labor? How do we support those communities? And how do we approach those communities to understand what they say they need? Also, I think we can definitely learn some lessons from permanent supportive housing and housing first models. If you're not familiar with these, I encourage you to look it up, but it's really focusing on providing housing first without a litany of requirements in order to get housing, including sobriety requirements. So I think what we've learned from this is if you provide services people say they want, those services will be more effective in terms of making people's lives better than if you provide them services you think they need. And we have all the evidence there from housing first models. And I think it also shows us, and I don't want to get into cost effectiveness too much, but I think sometimes you have to bring that up when advocating for these things, because sometimes that's the only thing people will listen to, as it is more cost effective in the long run to directly address an issue than to continue to deny services and discriminate people based on their drug use or housing status. And I think also when you look at some of the drug decriminalizations efforts across the United States, there's also some lessons learned there, and some are good, and I think some are not so great. But one that is, I think, a positive thing is that wide-scale policy change can dramatically affect the social landscape incredibly quickly. And if you go into areas where things were criminalized and then not criminalized, you see the cities and the states change, and oftentimes in positive ways and sometimes not. But I would not argue that the problem is with decriminalization. The problem sometimes is with how it's decriminalized. So when thinking about changing large-scale policies, I think equity has to be at the forefront, or the same people who usually benefit from policies will continue to benefit. And we have some areas in the US right now where people are making gobs of money with cannabis, and in that same locality or that same state, people are still sitting in prison or jail because they were involved with cannabis, and that is not equal. And we know that the people sitting in jail are more likely to be poor and more likely to be Black and brown. So again, with these big policy changes, we have to be thinking about equity. Okay, so I think that is about my time, and I would be happy to answer questions via email, or I think there's also